Let's interpret some x-rays. Lots of reasons to order a chest x-ray. We want to evaluate shortness of breath, chest pain, cough, unintentional weight loss. Maybe the patient had a positive PPD. Maybe we want to evaluate for rib fracture, secondary to trauma. Now there are risks associated with an x-ray. It is radiation, but that radiation exposure is pretty low, especially compared to a CT scan. Notice here we have the x-ray tube shooting the x-rays out toward the patient. An x-ray is a high energy photon. It's a form of high energy electromagnetic radiation, and it is going through this patient. Now this patient is getting a chest x-ray from the PA view, the posterior anterior, because it's shooting at the back of the patient. Most commonly, that is how chest x-rays are done. That's how you're going to get the best view. We'll talk about that in a second. The patient should be inspiring and ideally have his hands on his hips so his arms do not obscure the view. And then in front of the patient, we have the film plate, and that is where the image gets projected. So the x-rays are shooting through the patient and getting projected on that film plate. Okay, before we jump into anatomy, let's just talk about densities. Notice the bones are white, the lungs are black. Well, air is radiolucent. It appears jet black on an x-ray because the photons just go right on through. Where bone is radiopaque, it's white. The photons are blocked. And then in between there, we have fat, organs, blood, muscle. And depending on the radio density, those will appear some form of gray. Notice we have two chest x-rays here. We have the PA view and the lateral view. The lateral view is coming in from the side. And I encourage you, whenever you are doing a chest x-ray, always order both because they're going to give you the most information on that patient. Notice the lateral view gives you a three-dimensional view. I just want to remind you too that the image is flipped. So let's go to the PA view, locate the aortic knob. That's near the patient's left lung. So just remember the image gets flipped. All right, let's do some anatomy and we'll do the PA view, trachea. It's dark. Right at the top there. Now notice on the PA view, you cannot tell if it's in front of the vertebrae or behind it. And the vertebrae is the white bone with the little circles in it. Those circles are the spinous processes. I'm not talking about that circular thing. I'm talking about the black tube that you see right in the same area. Now if you look on the lateral view, you can see the trachea is in front of the vertebrae. The trachea should be midline. Follow it down to the carina, which you see on the PA view. And that carina is where the trachea branches into the right and left main bronchi. Now that angle, the carina angle, where it branches, should be less than 100 degrees. And if that angle is greater than 100 degrees, that can signify left atrial enlargement. And we're going to come back to all this. Also, trachea should be fairly straight. It will deviate away from air, like a pneumothorax, or it will deviate away from fluid, like blood collection or a tumor. So we want to see it nice and straight. Then we have the clavicles and the ribs. With the patient properly inspiring, you should be able to see at least 9 ribs. And the ribs that we see prominently displayed on the PA view are the posterior. Anterior is hard to see, but the anterior ribs, they appear to curve upward on the PA view. When we evaluate the bones, they should appear with similar lucency. Bone sclerosis, or bones that are lighter than the others or more white, Well, that can signify metastasis or a bone tumor, Paget's disease, osteomyelitis. And the clavicles should be level, and that is indicative of proper patient positioning. Let's move down to the aortic knob. That's the distal aortic arch as it curves to continue as the descending thoracic aorta. And this aortic knob is where we measure the mediastinum. The mediastinum is the compartment that runs down the thoracic cavity between the pleural sacs of the lungs. The pleural sacs are the outside of the lungs. And we measure the mediastinum right there at the aortic arch, and we'll come back to this. But it should be less than 8 centimeters. Mediastinal widening, which is greater than 8 centimeters, at the aortic arch or aortic knob with chest pain is aortic dissection until proven otherwise. An aortic dissection is a tear in the aorta that's life-threatening. Now, you can see mediastinal widening with an aortic aneurysm as well, but it's not something we want to miss. Continue going down, we have the right hilum and the left hilum. The hilum is where the vessels, the lymph, and the nerves enter and exit the lungs. The hilum should be symmetrical. Usually we do not see hilar lymph nodes. If we see enlarged hilar lymph nodes, they will appear lumpy and kind of bumpy in appearance. Where the vasculature, which you see right there on the PA view, you see the pulmonary artery, left and right, it's very smooth. Let's talk about pulmonary hypertension for a second, and we'll come back to this. Pulmonary hypertension is classically seen as enlargement of these two central pulmonary arteries with attenuation of the peripheral vessels. Attenuation means they appear whiter, they're more dense. Enlarged central pulmonary arteries are defined as greater than 15 millimeters for females or 16 millimeters for males. Now let's say you see enlarged lymph nodes in the hilum, and we'll certainly look at a few. What could cause that? Well, pulmonary sarcoidosis is number one on the differential. That's granuloma formation within the lungs. You can also see it with infections, especially tuberculosis. You can see it with malignancy too. Here is our patient's chest x-ray. Notice this is a PA view, posterior anterior view. It was shot from behind the patient. The AP view is shot from the front of the patient, but AP views are susceptible to the magnification of the heart and vessels because the heart is an anterior structure. It's like a hand puppet. The closer the hand puppet is to the light, the more magnified it is. Same thing with the anterior heart. We'll look at an AP in a second. But that is why PA view really is superior to an AP view. But the patient has to be able to stand in front of the film plate for a PA view to be performed. So if you're getting an AP view, either the patient can't stand, they're too sick, they're confined to a wheelchair, there's something else going on. Inspiration. Ideally, we should see 9 ribs, which we do in this one. We'll look at a slide where we count the ribs. Penetration is exposure. On the next slide, we're going to see what happens with overexposure and underexposure. Positioning, that's positioning of the patient. We want to see the apex of the lungs above the clavicles. So locate this patient's clavicles or collarbones and notice there is lung tissue above those clavicles. That's the apices of the lungs. We also want to ensure all of the lung tissue is fully in the x-ray, and we're going to look at some where it is not. And then rotation. The clavicles should be at equal height. Also, the transverse processes of the spine should be in the center of both clavicles. The transverse processes of the spine are those little white bony projections that extend off the back of each vertebrae. That's those little circular things you see right at the top in the middle. Remember, the trachea is in front of those. Okay, so I encourage you to look at this first picture, which is an AP view. Notice the patient is supine, it tells us in the upper right. And compare that to the PA view. This patient looks like he has cardiomegaly because the heart is so much more magnified on that AP view. Let's look at the second picture, or second and third, I should say, which is exposure. Underexposed x-rays are too white. Not enough time was given for the photons to pass through. So there's going to be an accentuation of the pulmonary vasculature. Compare that to overexposure, it's too black. The long exposure gives too much time and many x-rays pass through. So we can't even see the vasculature. Now, thankfully, with today's fancy electronic x-ray displays, we can dial up and dial down the exposure just on the computer. But still, we want to make sure that penetration is appropriate. Okay, you need to come up with a process to which you review your x-rays. We'll go over mine. Mine's A, B, C, D, E. A stands for airway. Start at the top, find the trachea. It's midline, and on the first picture, you see it's traced out for you. And remember, the trachea is the dark structure, not the white vertical line. The white vertical line with the circles in it is the vertebrae. So follow the trachea down to the carina and trace the right main bronchus and the left main bronchus. Sometimes that carina can be hard to find. One trick is if you find the clavicles, the carina is often anywhere from 2 to 3 ribs below the clavicles. So starting at the clavicles, you would go down 1 rib, 2 ribs, and usually between 2 and 3 is where you'll find the carina. And that's exactly the case on the second picture. If you start at the clavicles, count down 2 ribs, and then look between rib 2 and 3 down from the clavicle, and you can see very faintly the arch where the trachea branches into the right and left main bronchus. Remember, that angle should be less than 100 degrees. If it's greater, be thinking there might be left atrial enlargement going on. Also, you may notice the left main bronchus branches off at more of a horizontal angle than the right bronchus. And that's why most aspirated things go down the right side instead of the left. So looking at the second picture, is the trachea straight and midline? Yes, it is. Is the carina angle less than 100 degrees? Yes, it is. B stands for breathing. We want to assess for any asymmetry, allowing, of course, for the mediastinum, which is asymmetrical, but other than that, the lung tissue should be pretty symmetrical. Check each lung zone. And the lung zones are different than the lung lobes. The zones are just upper, middle, and lower. We're looking for any focal areas of increased density or increased whiteness. Then we want to check the sides of each lung. So go way up to the top, start at the apex, and trace down the lateral edge. That lateral edge, or the outside of the lung, should be sharp and well defined. You should be able to very clearly see where the lung starts and where it stops on the lateral aspect. Make sure that the costocardiac, or the inner lower edge, and the costophrenic, or the outer lower edge, are sharp and well defined. Then follow the hemidiaphragm inward to the spine, and then follow the inner lung back up to the apex. So we're starting at the top, we're going down the outside of the lung. Once we get to the bottom, we want to make sure that that outer edge is sharp and the inner edge is sharp, and then we're going to go all the way back up. And these lungs look really good. C stands for circulation and cardiac. Let's go over this. The mediastinum, again, that's the area between the pleural sacs of the lungs. We measure it at the aortic arch or the aortic knob, and it should be less than 8 centimeters. Greater than 8 centimeters is indicative of mediastinal widening. And thankfully, most electronic displays now have rulers. So you just pull up the ruler and you can find the mediastinal diameter very easily. If we haven't already, we want to check the carina angle. And you see that is the blue arrow. Should be less than 100. If it's not, think possible left atrial enlargement. And then we want to evaluate the hilar structures. The left hilum usually is a little bit higher than the right, and you can see those black arrows. The left arrow is the left pulmonary artery, and the right arrow is the right pulmonary artery. So you can see the arteries are white, they're smooth, and they're mostly symmetrical. Now, the right pulmonary artery is a little bit more pronounced on this patient, but it's smooth, no concerning signs there. Then we want to evaluate the cardiothoracic ratio. That dark orange line you see is the maximum horizontal cardiac width. So it's at the area of maximum width of the heart. And that yellow arrow is the maximum horizontal thoracic width. So you take the maximum horizontal cardiac width, which is orange, divided by the maximum horizontal thoracic width, and you should get a percentage less than 50%. Cardiomegaly is present if the ratio is greater than 50% on a PA view. Remember, we can't evaluate that on an AP view because the heart is going to be magnified in every case. And then D stands for diaphragm. We want to make sure those edges are nice and clear, well marked. The diaphragm should be domed or curved. Now that's far easier to see on the lateral view. But a flattened diaphragm is indicative of air trapping. Which condition would you see air trapping with? That's right, COPD. Also, we would want to evaluate for gas beneath the diaphragm. And that is with the GI lecture. But where would you see free air underneath the diaphragm? Perforation. Notice too on here, under the left lower lung, we have the stomach. This patient has a few normal gas bubbles in his stomach. And then E stands for everything else. So we want to evaluate for rib fractures, clavicular fractures, foreign bodies. Check out the stomach. We're just looking for anything else that's abnormal. And I know I fall victim to this all the time, but I think I go straight to the patient's lungs. And if those look fine, I'm like, oh, good, normal chest x-ray. But there's been many a story, especially in the ER, of clinicians missing a clavicular fracture or even a dislocated shoulder in a nonverbal patient because it wasn't evaluated for just the lungs were looked at. Let's look at some examples of everything else. Box 1, a massive diamond necklace. Okay. Box 2, SpongeBob SquarePants. Box 3, that female got some breast implants. Box 4, do you see the pacemaker? Box 5, we have leads in a patient who has pretty significant scoliosis. And what do you see in box 6? There's a baby. Now, we never want to x-ray a pregnant woman because of the fetus's exposure to radiation. Ultrasound is far safer. There's a little baby growing in there. Let's implement that evaluation process right now. But before we do the first chest x-ray, let's look at the second one. Those are the lobes of the lungs. Not the zones, the lobes. The red box is the right upper lobe. Green is the right middle lobe. And notice the purple is the right lower lobe. It's pretty small. The yellow is the left upper and the blue is the left lower. The left one has only 2 lobes because of the heart. Let's go through this systematically. We're back to the first chest x-ray now. We have a PA view. That means the patient is at least able to stand. They're not sticking off that they're bedridden. The exposure is good. What do you think about positioning? Are the clavicles at equal height, equal level? They are. Do you see any rotation? Yeah, the patient was rotated just a little bit. It looks like to his right. But otherwise, this is a good x-ray. Let's do airway. The trachea is curved a little bit. That's probably due to the patient's rotation because I don't see any free air or anything that could be pushing the trachea to one side. I marked on there with a blue arrow the carina. That's where the trachea branches off. This patient's is less than 100 degrees, so that's good. B is breathing. Let's start with the apices, or the top part of the lung that's above the clavicles. Looks good. Upper zones look just fine. What do you see in the right middle and right lower lobes? Notice that increased density, that whiteness. It's asymmetrical. You don't see it on the left side, the left lung. That increased whiteness is consolidation or an opacity. Also, if we go down the lateral side of the right lung, it's not well demarcated. There's just all this whiteness. So that patient has something going on in the right middle and right lower lobes. Cardiac looks good, diaphragm looks good, bones look fine. What do you see in the stomach? That's a humongous gas bubble. So this patient was pretty gassy, but otherwise everything looks good. What are our differentials for this consolidation? Well, right at the top is probably pneumonia. That's how pneumonia appears on a chest x-ray. Now that could be bacterial, viral, fungal, but pneumonia is at the top of our differential. Upper respiratory infection and bronchitis usually don't appear on a chest x-ray. Now that whitened consolidation could be malignancy, it could be vasculitis, it could be a pulmonary infarction or dead lung tissue secondary to a pulmonary embolism. Now we can't see a pulmonary embolism on the chest x-ray, but we can potentially see the infarction that would be a complication from a long-standing PE. That consolidation can be pulmonary hemorrhage if the patient had severe trauma. So I just want to point out, we cannot look at this x-ray and say, yep, that patient's got pneumonia. But what we can say is, well, the patient has a fever, they're coughing, they have rails on exam where we hear crackling in their lungs, and they have this chest x-ray. Okay, that picture combined with this chest x-ray leads us to suspect pneumonia. Which, by the way, this chest x-ray is of pneumonia. Pneumonia is air-filled bronchus surrounded by pus-filled alveoli. And because the alveoli are filled with that pus, the x-rays don't penetrate. So we get that whiteness. How would you describe this x-ray? Well, we would say there is consolidation in the proximal aspect of the right middle lobe and right lower lobe. I do think that this is a good time as well to point out that dehydration in a patient with pneumonia can cause a lack of a consolidation on x-ray. That pus that's in the alveoli during pneumonia is mostly composed of water. So the patient needs to have enough water on board for it to show on a chest x-ray. So if we have a severely dehydrated patient with pneumonia, the x-ray can potentially be normal. But in most patients, that consolidation with pneumonia appears within 24 hours of symptom onset. But if the patient came in really early, within 24 hours of symptoms, general consensus is if your spider sense is going off for pneumonia, but the patient has a normal chest x-ray, treat it as pneumonia and repeat the chest x-ray in 2 to 3 days. And here we have cardiomegaly. The length of that blue line is greater than 50% of the length of the orange line. It's cardiomegaly. Notice though, this is the AP view. So let's say we did not notice that. We could have diagnosed that patient with cardiomegaly, but it's an AP view. We really can't diagnose anyone with cardiomegaly. A PA view really is needed. So I just threw that in there to remind you of the importance of looking at the view. Let's switch things around. Let's say this is the PA view. Then we could diagnose that patient with cardiomegaly. What would be the differentials? Well, at the top is congestive heart failure. You can see cardiomegaly with valvular disease. That would be secondary to an infection like endocarditis or an arrhythmia like AFib or lupus. We can see cardiomegaly with pulmonary hypertension, with pericarditis, or pericardial effusion. So again, a chest x-ray, you can say, yeah, that patient looks to have cardiomegaly, but it's really looking at the patient as a whole to determine the proper course of action. Just a quick slide on COPD. Now, early on in the course of COPD, the chest x-ray is going to be negative. It's going to be normal. But as the disease progresses, you can see increased radiolucency of the lungs. They appear more black. And that's because there's more air in there. And a flattened diaphragm can be seen, especially on the lateral view. There should be an arch there. But because of the increased air in the lungs, because of air trapping, it flattens out the diaphragm. And here we see an example of hilar lymphadenopathy. So the white arrows, those are pointing to the hilar lymphadenopathy. Now notice, that kind of looks like pulmonary vasculature. It's hard to differentiate. But this hilar lymphadenopathy, it's nodule. It's kind of bumpy, it's kind of lumpy. Where pulmonary vasculature is very smooth and more streamlined. It's not lumpy in appearance like this lymphadenopathy is. The yellow arrow is pointing to paratracheal lymphadenopathy. And then if you look very closely, you'll see a scattering of several small nodules too. I pointed to one of them with the green arrow. Just several small little white dots. And those nodules are small, round-shaped growths within the lungs. So what can cause nodules? Well, infectious processes like tuberculosis or even non-tuberculosis mycobacterium. We can see it with fungal infections. They can be totally benign. These can be calcifications, fat, muscle, tissue. They can be an inflammatory response to lupus, RA, sarcoidosis, or other autoimmune diseases. Now this patient has sarcoidosis. There's a triad for sarcoidosis, and that is the nodules, bilateral hilar lymphadenopathy, and then paratracheal lymphadenopathy. And here's another consolidation. Notice this patient has opacity or consolidation in the right middle and right lower lobes. But just from this chest x-ray, we don't know what that consolidation is. This guy turns out to have tuberculosis. But notice, if you just looked at that, you might say pneumonia. And that's a fair guess. That's what I would say without knowing the clinical picture. But we really have to put the puzzle pieces together. Okay, so what do you see in this? Is the trachea midline? Not at all. It's branching way off to the right, and you can see a white consolidation that's pushing it to the side. There's also several scatterings of areas of consolidation. Notice the two blue arrows. Those are fairly ill-defined, but over time they'll probably become more circumcised. This is, by the way, granulomatosis with polyangiitis, the autoimmune vasculitis. And then I just threw this in here to show you pulmonary hypertension. So the pulmonary hypertension, notice how large the pulmonary arteries are. And you can differentiate those from hilar lymphadenopathy because these are more smooth in appearance, more streamlined, they're not as lumpy. Another way to tell too is the rest of the chest x-ray looks pretty decent. We don't see any areas of consolidation that would cause the lymph nodes to become enlarged. All right, we have a patient who comes in, he's years of coughing, productive cough, years of shortness of breath, and it's getting worse. He smokes, no family history of cancer. Father died of a heart attack at age 81. All right, so lisinopril we know can cause dry cough. His is productive, so probably not due to lisinopril. Zocor would not cause a cough. Aspirin in certain patients can cause a cough, but that would be probably earlier onset than this guy. So we're not thinking it's due to any medications that he's on. Let's go over the differentials. COPD right at the top. He could have asthma, he could have a combination of both. He could have an infection. This has been going on for years, but he could have tuberculosis. Definitely lung cancer. He could have congestive heart failure or some cardiovascular etiology. What's your workup? Well, let's start with serum studies. We want to do a CBC looking for anemia. He's short of breath. Check a TSH and a comprehensive metabolic panel. We want to look at his electrolytes, glucose, renal function, and hepatic function. We want to rule out congestive heart failure. So let's draw a brain natriuretic peptide, BNP. Is he a candidate for a chest x-ray? Absolutely. Is he a candidate for a low-dose CT scan? Well, for screening purposes, yes. He smokes and he's between the age of 50 and 80. He's smoked at least 20 pack years. So if he hasn't had one within the last year, now's a really good time. Should we do spirometry? Absolutely. COPD is right at the top of our differential. What about an EKG? Yeah, he's short of breath when he exerts himself. Stress test? Let's wait on the stress test. Let's see what the rest shows. The EKG, spirometry, and imaging, and lab tests. If those are all normal, stress test would be a good next step. He's not anemic, he doesn't have hypothyroidism, and his BNP looks fine. Normal is less than 100. Greater than 100 would increase our suspicion for congestive heart failure, but that all looks good. This is just a little bit of foreshadowing from our EKG interpretation lecture, but he has right axis deviation. The right ventricle is working hard due to a pulmonary abnormality. Now in COPD, the chest x-ray can be normal. But when it gets severe enough, eventually you're going to see enlarged and hyperinflated lungs, and that's going to cause the diaphragm to flatten. So there's two things to look for, and both of these are seen on lateral. The first thing, notice the sternophrenic angle, that's the anterior aspect, and the posterior costophrenic angle. And I pointed those out on the lateral with some arrows. Between those two angles, we would draw a straight line, and that's that purple line. The dome above this line should rise at least 1.5 centimeters. If it is less than 1.5 centimeters, which it definitely is in this patient, it is indicative of a flattened diaphragm secondary to hyperinflated lungs. The second thing to look for is the retrosternal airspace. The retrosternal airspace is the dark area behind the sternum. It's the normal lucency that occurs between the back or the posterior aspect of the sternum or the breastbone and the anterior aspect of the ascending aorta. So we're on the lateral view. Look at this guy's chest, and you see that darkened area. It should be less than 2.5 centimeters. If it is greater than 2.5 centimeters, it's indicative of hyperinflated lungs. So we're looking at those two areas. Let's repeat. The dome above the purple line, it should rise at least 1.5 centimeters. If not, think COPD. And the retrosternal airspace should be less than 2.5 centimeters. If it's greater, think COPD. So let's compare that to a normal chest x-ray. So look at the ascending aorta, that's that retrosternal airspace. Notice it is less than 2.5 centimeters. And notice the arch, the diaphragmatic arch. It is greater than 1.5 centimeters. So this is normal lung, not hyperinflated lungs. So let's go back to our patient. Well, it sure sounds like this guy has COPD, but can we diagnose him yet? Not quite. We need spirometry. Let's look at his FEV1 FVC ratio. Is it less than 0.7? Yes, it is. His is 0.37. So we know he has obstructive lung disease. Is it asthma or is it COPD? Well, let's look at his FVC and FEV1 pre-bronchodilator and post-bronchodilator. Is there a change of at least 12% and at least 200 milliliters? No. He had a change of 12%, but his improvement was only 80 milliliters. It's not significant. He has COPD. Now we need to stage it. Let's look at his post-bronchodilator FEV1. It's at 23%. His CAT score is 30, and his modified dyspnea scale is 3. So go to the slide with the staging. Where do you stage this patient? He has severe COPD, stage E. What's our treatment plan for this guy? Well, we have to make sure he gets a PPSV 23. He needs a one-time serum alpha-1 antitrypsin. Make sure he's not deficient. He should have a short-acting bronchodilator as a rescue inhaler, and preferably a LABA-LAMA combination, as long as there are no contraindications. What else would we consider for stage E? Well, an inhaled corticosteroid. But what do we know about those in COPD patients? They increase the risk of pneumonia. So there's a trade-off. Let's hold off on that. Let's see how he does with what we're currently prescribing him, see him back in 4 to 6 weeks, and reevaluate. Pneumothorax is gas in the pleural space, that's the fluid-filled space surrounding the lungs. A tension pneumothorax causes vascular compromise due to a mediastinal shift. That's where the heart, the bronchi, and part of the trachea actually shift over because of the presence of the pneumothorax. It's an emergency. We'll do several x-rays to show how to diagnose and how not to miss a tension pneumothorax. But a pneumothorax manifests as acute onset shortness of breath and chest pain. Patient will likely have a low pulse oximetry, they'll be tachycardic, but otherwise the exam is kind of non-specific. On the chest x-ray, we're going to be looking for a visceral pleural edge of a thin, sharp, white line. We're also going to be looking for asymmetry. These can be bilateral. Most often, though, they're only on one side. We're going to be looking for a darkened area with no underlying vascularization. And then that faint white demarcation line on the x-ray. We'll do several examples. So notice on the first chest x-ray, there is asymmetry and there's a darkened area with no underlying vasculature. Looks like he's also developing one on the left upper area. And then on the second chest x-ray, you see the bilateral pneumothorax. And here we have a tension pneumothorax. So notice this patient has a left lung pneumothorax. The whole lung is pretty much darkened with no underlying vasculature. And that pneumothorax is pushing the heart and other anatomical areas away from the pneumothorax, so it's pushing it to the right. There's a mediastinal shift to the right because of the pneumothorax. That's a tension pneumothorax, and that is an emergency. Let's look at this second one. You can see the pneumothorax on the right. The entire right lung is darkened with no underlying vasculature, and there's a mediastinal shift to the left. Tension pneumothorax. Incidental lung nodules are so common. You'll send the patient off for a chest x-ray. It'll get overread by the radiologist and it will say, no acute processes, but lung nodules seen. You're like, what do I do with this? Well, a lung nodule may be cancer, or it may be cartilage, fat, muscle, fibroblastic tissue. So it could be totally normal or it could be cancer. Well, what are the clinical features associated with malignant lung nodules? For those under the age of 39, only 3% are malignant nodules. When those nodules are found on an elderly patient, that risk drastically increases. Smoking history and family history, and then the size plays a role too. So notice if that nodule is 2 centimeters or greater, there's a 50% chance or more that that's cancer. So when you see a lung nodule, look at the size and the characteristics, but also consider the patient's age, smoking history, and family history as well. This case study may be a little bit unfair because when we get to the diagnosis, we have not talked about that specific diagnosis yet. But I used this case study to show how to walk through the workup for a chronic cough. Okay, 33-year-old male, persistent cough for 5 weeks, chest pain when he coughs, fever off and on from days 4 through 10, coughing spells last 2 to 4 minutes, multiple times throughout the day. It is productive and he's short of breath. Prior treatments, he's had a Z-Pak, he's had prednisone, and he continues to use his albuterol. He's on Lexapro, dad with colon cancer. He's married, he's a plumber, drinks a little bit of alcohol, denies smoking. Okay, so here's your exam. Temperature is a little bit elevated. Cardiac looks good. Check out respiratory. He has rales. He has decreased breath sounds. What do you order on this guy? Well, before we even get to that, what should have been done as part of this exam but was not done? Pulse oximetry. That can really help you narrow your differential diagnosis list. This patient should have had a pulse ox. So what would be your next step? Let's start with serum. Which serum studies would you do? Well, I would do a CBC and a CMP. This patient on CBC had elevated white count. It was 19,000. Differential was not done. His CMP was fine. Would you order a chest x-ray on this guy? Hopefully so. Let's look at what his chest x-ray shows. Notice in the right upper lobe he has consolidation. He was now diagnosed with pneumonia. He had been on azithromycin. Would that cover for atypical or typical pneumonia? It would cover for atypical, but strep pneumo is resistant, about 30% or so, 30% resistant to azithromycin. So he was treated now with Augmentin and asked to follow up within 3 days, which he did. He was no better. So what would be your next step now? Would you expect to see improvement with Augmentin? Yeah. Well, next step, he has consolidation, so TB is within the differential, so we drew a quantiferon and a CT scan. And the CT scan showed round lesions suggestive of small cavities. Upon culture, he was diagnosed with blastomycosis. He had a fungal infection of the lungs. But the consolidation of blastomycosis is indistinguishable from pneumonia. And that just shows you the importance of continually following up with your patients and use further imaging, further studies to find out what's going on. So for these, we're going to do rapid fire. So pause it, and then diagnose it yourself, and then unpause it, and we'll see if you were correct or not. So I'll give the answer in 1, 2, 3. Left lung pneumothorax with surprisingly no mediastinal shift. Answer in 1, 2, 3. Left lower lobe pneumonia. Answer in 1, 2, 3. This patient swallowed her toothbrush. She's bulimic. Notice the dark spot within the esophagus. Interestingly enough, the tips of the bristles are radiodense, but the plastic handle is not. Answer in 1, 2, 3. Left pneumothorax with mediastinal shift to the right. Answer in 1, 2, 3. Right upper lobe, possibly middle lobe, no, that's upper lobe. Right upper lobe pneumonia. Answer in 1, 2, 3. This is right lung cancer. So notice that could be hilar lymphadenopathy. It's kind of lumpy bumpy, but it's a little large for that. It's definitely too large for pulmonary arteries. Borders are well defined. That turned out to be lung cancer. Answer in 1, 2, 3. That is also right lung cancer, right middle lobe. One, 2, 3. This patient aspirated a tooth. Check out the right bronchus. Answer 1, 2, 3. These are breast implants. Okay, let's put this all together with case studies now. DL is a 65-year-old missionary, 2 to 3 days of chills, productive cough, shortness of breath, and fatigue. He's been taking guaifenesin or Mucinex. Doesn't help. He's been taking ibuprofen. So that could mask any fever. We would want to know his last dose. No blood in his sputum, no blood in his urine, no stool changes, chest pain, or headache. He's been relatively healthy. He is a pipe smoker. So he has an elevated temp, an elevated pulse. Respiratory rate is up there. Pulse ox is only at 95. Blood pressure is elevated. And he has expiratory rales over his right mid lung. Okay. What do you do next? Well, let's go over the differentials. What are the differentials for this guy? He has a fever. He's short of breath. He has a productive cough. He's fatigued. And his pulse ox is 95. Well, hopefully right at the top, we're thinking pneumonia. We hear rales. Remember, rales in the tails means it's coming from the alveoli. Rales is the fancy word for crackles. Sounds like Rice Krispies. Now, this pneumonia could be bacterial, it could be viral, it could be fungal. He is a missionary. I'd want to know, hey, did you just come back from a third world country where the risk of a parasitic infection or something else is elevated? He could have COPD. Now, it could be undiagnosed. It is a gradual process. And he could be having a flare in his already undiagnosed COPD. He could have the flu. He could have URI or bronchitis, but we probably wouldn't hear crackles and a fever with a typical common cold or bronchitis. He could have tuberculosis or sarcoidosis. With sarcoidosis, you often have a fever for a few months, a few weeks to a few months, I should say. He could have congestive heart failure. We definitely hear rales and a cough and shortness of breath with congestive heart failure, but he has a fever too, so we're going to move that one down on the list. He could have a PE, but he's denying chest pain, he has a fever, we'll move that one way down. He could have lung cancer, but this is kind of an abrupt onset for lung cancer, plus again he has that fever. He could have had a long-standing infection and now he has an abscess. Or he could be having some autoimmune inflammatory disease state, like granulomatosis with polyangiitis. With that, we would see a fatigue, fever, shortness of breath, arthralgia. So what do you do? What do you do for this guy? Let's start with blood work. Which lab studies do you order? Well, we probably want to do a CBC with differential. We want to evaluate for infection, elevated weight count, and inflammatory response. I would order a comprehensive metabolic panel on him, a CMP. I want to know his hepatic function, his renal function. If nothing else, then it will help me dose my medicine appropriately for whatever I'm going to prescribe him. Now, you could consider a brain natriuretic peptide for congestive heart failure if you wanted. You could consider spirometry, but it's going to be abnormal. He has a fever, he has some lung process, there's something going on. And you could do an autoimmune workup too, but let's start with the CBC and CMP, and of course, a chest x-ray. He's short of breath with a cough, and see where that leads us. White count looks good. That looks okay. Okay, here's your chest x-ray. Do you like it? Well, let's go over it. It's the posterior anterior view. What do you think about the exposure? It's not ideal. Plus, notice you cannot see the costophrenic angles. You can't see the very bottom tips of the lungs. So that's kind of frustrating. But let's start with A. A is airway. The trachea, is it straight? Well, the part of it we can see, yeah, but we can't see the proximal part. We can't see the carina. Breathing. Let's start with the apices, the lung tissue above the clavicles. That looks fine. Do you see any asymmetry though after that? Yeah, he has a scattering of nodules, and in the right middle zone, he has that area of consolidation, that whitened circular area. What else do you see? Let's look at the hilum. Do you see hilar lymphadenopathy? He does have it. It's more pronounced on the right, but he has this lumpy kind of coarse appearance to that area. Cardiac looks okay, bones look okay. We can't see the scapula, so we can't comment on that. So what would you do now? His CPC looks good, his CMP looks good. Chest x-ray, we have consolidation, hilar lymphadenopathy, and a few nodules. Well, what are our differentials now? Still cancer, still infections like pneumonia or tuberculosis, but with pneumonia or tuberculosis, would you expect some change in the white blood cell count? Yeah, but he does have a fever, so that's making us think infectious. Or you could still have some inflammatory autoimmune disease. So we've narrowed it down to those three. So what do you do now for this guy? What's your diagnosis? Well, he was diagnosed with pneumonia, and he was treated with doxycycline for 10 days. And just like every patient with pneumonia, we want to see them in the clinic within 3 days. So he does come back. He's no better, no worse. So number one question, are you taking the doxycycline? Are you tolerating it okay? He is. He's having some side effects, but he's taking it. Should we see improvement within his fever by now? Yeah. With pneumonia, you should see vast improvement within 3 days. What about his cough? Well, we can't go by that. The cough can linger for weeks, and the consolidation can be there for 4 weeks. But his fever should be much improved, and he should be feeling somewhat better. So the fact that he is not, well, that's kind of concerning. So we repeat that x-ray. What do you see? Well, the hilar lymphadenopathy is worse, and the consolidation is way worse. So what do you do for this patient? Well, let's go to the next slide. We want to evaluate for tuberculosis. Will tuberculosis respond to doxycycline? No. So you'd want to order either a quantiferon gold or a PPD plus a sputum culture. He could have atypical pneumonia. We know that there are the atypical bacteria that can cause pneumonia. And that's where the sputum culture may help. Now, he has been on doxycycline, so that's going to muddy the waters of the culture a little bit. But at this point, it may be beneficial. Maybe draw some blood cultures. He still could have an abscess. He still could have cancer. But would you expect cancer to grow that quickly? Not in 2 days. Could he still have an abscess? Absolutely. Could he still have an inflammatory autoimmune disease? Yes. And because of that, the next step we need to do should require further imaging. It's time for a CT scan. We need to do the CT scan, a sputum culture, probably recheck his CBC, and then check his quantiferon gold. What about these autoimmune diseases? There's several that could be causing this. We have granulomatosis with polyangiitis, or Wegener's granulomatosis was the original name. It manifests in the sinuses, lungs, and kidneys. He could have good pasture disease, blood-tinged urine, and blood-tinged sputum. This guy's findings were significant for an autoimmune vasculitis. And you can see then the importance of this chest x-ray and then how it can guide where you go based on the results. Okay, so please read over this case study on CS. Notice he is coughing up blood-tinged sputum. So what is your differential for a guy with an elevated temp who's coughing up blood-tinged sputum? Well, he could have an acute infection. He could have pneumonia, tuberculosis. He could have a viral thing like dengue fever. So I'd want to know, have you traveled? Could have cancer. Could have an autoimmune disease like good pasture disease. Remember, with good pasture, blood in the urine, blood in the sputum. And the younger the patient with good pasture, the more common that it manifests solely in the lungs. You could have granulomatosis with polyangiitis. You could have a cardiac thing like congestive heart failure. Now, while we do see blood-tinged sputum with congestive heart failure, this guy's a little young and a little too healthy, but it remains on the differential. He could have a bleeding disorder. He could be snorting cocaine. Or he could just be coughing out blood that's dripping down from the upper airway. And I'll tell you what, at least in my practice, that's the most common. The patient will come in, hey, I'm coughing up all this blood. You know, and you look up in their nose and it's all dry and you see dried blood in there and you're like, okay, I'm not quite as worried about this. Notice on exam, it is normal. Nothing really serious pops up. What's your next step? What do you do for this guy? Which labs do you order? Well, we'd want to do a CBC with differential because we're evaluating for infection, inflammation. We want to look at his H&H and his platelets because he is bleeding. Comprehensive metabolic panel, I want to know his hepatic enzymes and his creatinine. I would recommend checking a urinalysis to look for blood. We would want to do a PT-INR, looking for coagulopathies. And of course, a chest x-ray. So he has an elevated white count, so he has some infectious or inflammatory process going on. His urinalysis has protein. Nothing else looks too concerning. Let's look at his chest x-ray. What do you see there? Multiple bilateral consolidations. You can just see all the different circular white areas scattering both sides of his lungs. So what do you want to do for this guy? What's going on? Well, there's some lung process going on. We know it's not cardiac. So we need to do further evaluation of these consolidations with a CT scan, a sputum culture, and then consider quantiferon gold for tuberculosis, consider an ANCA, ANA, an anti-GBA, and we're thinking good pasture with that, and a urinalysis. Okay, this guy's anti-GBA was positive. He has good pasture disease. Okay, let's do another guy. A few things I'd like to point out. Several weeks. So the other two guys were more acute. This is more pronounced. He's having a dry cough with shortness of breath. He has some chest pain when he coughs. He's fatigued with general achiness. Notice his vitals look good, and his exam looks good. Let's go to the next slide for the differential. Here's your differential list. What do you order on this guy? Anytime a patient has chest pain of any magnitude and shortness of breath, always order a chest x-ray and an EKG. Right off the bat, you will not go wrong with an EKG and chest x-ray. Is he a candidate for spirometry? Yeah, but let's start with some labs, EKG and chest x-ray. Which labs do you order? I'd recommend a CBC with differential, because we're thinking infectious or inflammatory process. A comprehensive metabolic panel. We'll check his electrolytes, renal, and hepatic function with that. He is fatigued with joint pain. I would order an ANA and a rheumatoid factor on him, plus a thyroid stimulating hormone because of his fatigue. There are many things you can consider, but that'd be a good place to start. Let's start there. But in the back of our mind, if all that comes back normal, consider spirometry, a stress test or a stress echo, a brain natriuretic peptide. A lot of stuff we can do. Let's start with the basic and let those results guide us. White count looks good. CMP looks good. TSH looks fine. ANA, that's a low titer, which is good. And his rheumatoid factor is negative. EKG looks great. So that looks pretty good. Okay, I encourage you to pause this lecture, go through this chest x-ray with a systematic approach, unpause it when you're ready, and we'll go over it together in 3, 2, 1. Notice the left lower lobe is not fully visualized. This is not the best chest x-ray. What do you see? What do you see on the hilum? Those enlarged things that look like marshmallows. Is that A, bilateral hilar lymphadenopathy, or B, enlarged pulmonary vasculature? Notice it's lumpy, bumpy. That is hilar lymphadenopathy. He also has paratracheal lymphadenopathy. So what's our new differential list? Well, he could have some atypical pneumonia, but again, his CBC was normal. He could have tuberculosis. We would expect to see an elevated white count, but because of the bilateral hilar lymphadenopathy, we absolutely have to rule out tuberculosis. So do a sputum culture on this guy, and probably a serum quantiferon. He could have sarcoidosis. What's the number one sign and symptom of sarcoidosis? Bilateral hilar lymphadenopathy. He could have autoimmune. He could have cancer. But with autoimmune, which two things are we thinking? Granulomatosis with polyangiitis, but we see nodules with that. Or Churg-Strauss. With Churg-Strauss, we see an elevated eosinophil count. 100% of patients with Churg-Strauss have elevated eosinophil count, so we can rule that out. We can cross that off. 85% of patients with granulomatosis with polyangiitis have pulmonary nodules, so we can't rule it out. We can't cross it off, but we can move it down. So because of this guy's presentation, he has either tuberculosis or sarcoidosis. So we get the sputum culture, we get the quantiferon gold, we get the CT scan. And it turned out to be sarcoidosis. Now, some of you may have come across with sarcoidosis. I just want to point out one thing. So, or you may even see your preceptor order an angiotensin converting enzyme through the blood. And that's fine. So with sarcoidosis, an ACE will be elevated. But there's a whole lot of other lung processes that can also elevate the ACE, like lung cancer. And there's just, the list goes on and on, just dealing with the lungs. Then it can also be elevated with diabetes and so on. So me personally, I don't order an ACE because it doesn't change the need for a CT scan, sputum culture, quantiferon. Even if it was elevated, I'd be like, well, so we gotta do those things anyway. But you know, you might see it. So I'm not skipping over it, just want to point that out. Okay, please work through this one. I'll give you a hint, he's a Marvel superhero, so he's gonna bounce right back from this. He'll be just fine. Okay, so what other information do you want to know? Well, let's start with coughing out blood. What do we want to know? We want to know how much. Is it mixed with the phlegm, or is he coughing up straight blood? Is it new or recurrent? Is the patient experiencing bleeding from the nose, gums, within the urine or stool? We might be thinking infection. Is there a fever, chills, night sweats? We might be thinking autoimmune. Is there a rash or joint pain? Does the patient smoke? Which medications is the patient on? Has the patient traveled recently? Possible exposure to tuberculosis? What is the patient's family history? And here is our differential list. This guy's white count looks good. Now we can't rule out infection, but we can rule out anemia. So he's not suffering hidden blood loss from other causes. Platelets look good. CMP, his glucose is elevated, but he's diabetic, so that's not overly concerning. Liver looks good, kidneys look okay. PT is within normal range, so low concern for a bleeding disorder. Thankfully, no blood in the urinalysis, so low suspicion for glomerulonephritis. What else would you order on this guy? Well, he certainly has risk factors for congestive heart failure. Let's draw that and then get his chest x-ray. Okay, BNP elevated, but not significant enough to where we'd be thinking congestive heart failure, especially without pedal edema. What do you think about this chest x-ray, though? Trachea is midline. I don't see any consolidation. Do you see enlarged pulmonary arteries, or do you see hilar lymphadenopathy? Yep, that looks pretty coarse. That is hilar lymphadenopathy, so top two things on our list, sarcoidosis or tuberculosis. Let's do a CT scan, quantiferon, and sputum culture. All right, let's change focus to the abdominal x-ray next. All right, so let's talk about the abdominal x-ray. Now we're going to do tons and tons of examples, but basically you're only going to order an abdominal x-ray if you want to evaluate for free air or bowel obstruction. If you diagnose the patient with constipation, that can't be off an abdominal x-ray, it's just off of the patient's symptoms. We all have stool. And some of us are just more full of it than others. It doesn't mean we're constipated, we just have more stool. Let's start with the left one. You can see where the organs are located within the abdominal plane film. So the liver is on the upper right quadrant, extending into the left. Spleen you can't always see on a plain film. Gallbladder you can rarely see on a plain film unless there's calcifications. The large intestine is on the peripheral aspect, and it contains haustra, H-A-U-S-T-R-A. These are wider spaced than the small intestine valvular markings. So that's one way to differentiate the large intestine from the small intestine. The valvular markings of the large intestine are wider, and plus they often do not connect from one wall to the opposite wall. Compare that to the valvular markings of the small intestine, which are known as valvulae conniventes. That's two separate words, V-A-L-V-U-L-A-E, C-O-N-N-I-V-E-N-T-E-S. That's the valvular markings of the small intestine, and they do cross the entire width. So they're going to go from one wall to the opposite wall, and they look like stacked coins. And then on the stomach, you can pick out the stomach on the plain film because it has large gas bubbles. That's normal. You know, we all have a little gas, and you can pick that up on the plain film. So your interpretation, I recommend you start with A, air. You're looking at the large bowel and the small bowel. If there's gas inside, you'll see it. You'll see gas bubbles. B stands for bowel. That's small bowel, which is proximal to the rectum on the patient's left side, and large bowel, which is along the periphery. In this patient, the far right x-ray, you can see the mottled fecal matter along the periphery, that right-hand side, in the large intestine. D, dense structures
You'll want to evaluate the vertebrae, the pelvis, and the ribs. And then O is for organs. So on this patient, on the right-hand side, you can pick out the outline of the liver. Occasionally, you can see renal stones on a plain film, but not all the time. You're rarely going to see gallstones. They're just not radiolucent enough. There's not enough calcium. And then X stands for external objects. So an IUD or the clips from when a patient had their gallbladder removed. You can find all sorts of different stuff. On the left, you can see the large intestine outlined, so please use that image in your mind to trace the large intestine on the patient on your right. The normal diameter of the large intestine is less than 6 centimeters, except for the cecum where it's less than 9. The normal diameter of the small intestine is less than 3 centimeters. So obstruction is much more common in the small intestine. It is also normal to have 2 to 3 air fluid levels within the intestine. So if you see 3 or more air fluid levels and an enlarged intestinal diameter, you need to be thinking there's obstruction going on. I also want to point out that on abdominal plain films, you should see the hemidiaphragm. You should see the bottom part of the lungs. Otherwise, it's not a good x-ray. If you can't see ribs and some lung tissue, it's not a good abdominal plain film. So you want to evaluate for free air, which would be indicative of a perforation. Air rises to the top. Air will rise to the top of the bowel. And that is why abdominal plain films really should be shot with the patient sitting or standing, because that free air will rise to the hemidiaphragm. So you will, remember, gas is black on an x-ray. You will see blackness under the hemidiaphragm, and that it would be indicative of free air. If the patient is laying down, it's really hard to find. So on this patient, on the right, I just used it for 2 reasons. Number one, you can clearly see her large intestine. And then you can also see umbilical piercings. You can see fallopian clips. And you can see the buttons of her pants. Okay, so let's start with this left one. The white line is the hemidiaphragm. So this is not an abdominal plain film. This is a chest x-ray of the lungs. But I just used it because that white line is the hemidiaphragm. That's the bottom part of the lungs. And that black line is free air. What about on the right? The free air is much more pronounced. It's over her breasts. But you should not see gas in that area. That is a perforation. So when would you see a perforation? Generally secondary to a colonoscopy if the surgeon just kind of messed up a little bit. And I mean, it's just a risk of the procedure where you can have a perforation. You can see it as a complication of diverticulitis, of inflammatory bowel disease, of toxic megacolon. And the symptoms are going to be abdominal pain and vomiting. But in most cases, it is going to follow some sort of surgery. All right, let's go back to the abdominal plain film. So a few things here. Notice her liver. This is on the first picture. That liver is very, very prominent. And that's actually okay. That's a normal variance of the liver. On her, you can also see her fallopian clips. And she has a lot of feces. So if you follow the large intestine, and you're going on the right-hand side, on the periphery, there's just this mottled fecal appearance. That's stool. And she has some small gas bubbles as well. And on the right-hand side, you can follow the large intestine. And as you go down to the patient's right side, we're looking at the left side, you see a razor blade. This patient swallowed a razor blade. but there's no perforation. Look at the hemidiaphragm. There's no free air. So that patient swallowed a razor blade and they're fine. They're just going to kind of have to get rid of it because there's no perforation, which is fantastic for that patient. Okay, what's going on with this patient now? I'm talking on the first x-ray. You can see multiple air fluid levels. You can see distinct, large, circular air bubbles. That is where the fluid and the gas collect. So air rises above the fluid, and there is a flat surface at the air-fluid interface. So you can see the flatness, and then there's the ovular part above it. That is an air fluid level. That is obstruction. This patient has obstruction and needs to be sent off to surgery. What about on the right? Well, we see some intestine. What are we looking at on the right? And I'm talking the right hand x-ray, the second x-ray. Are we looking at the small intestine or the large intestine? Well, look at the valvular markings. Look at the lines in between the intestine. Do they connect from one side to the other? Yes, they do. So we're looking at the small intestine. Is that greater than 3 centimeters? Yes. That is an enlarged small intestine. So that patient also has obstruction. Okay, what about the first one here? Which part of the intestine are we looking at? Which one is dilated? Well, do the valvular markings touch one wall to another? Yeah. So we're looking at the small intestine. Those are valvular coniventes. It is enlarged, and you can see multiple air fluid levels, multiple large, dark air fluid levels. That patient has obstruction. What about the second x-ray? Well, let's start with the intestine. Which intestine are we looking at? Well, the valvular coniventes extend from one wall to the next, so we're looking at the small intestine. And you can clearly see multiple air fluid levels. So that patient has a small bowel obstruction. All right, what about this first one? Is that the small intestine or is that the large intestine? That's the small intestine. Is it enlarged? Yes. Are there air fluid levels? Yes. So that patient has small bowel obstruction. What about the one on the right? Are we looking at the large or small intestine? Well, the valvular markings do not extend from one wall to the next. That is the large intestine. It is very, very enlarged. That is a large bowel obstruction. Very rare to see. Usually it's going to be small bowel. On the first picture, you don't see any free air. There's no perforation under the hemidiaphragm. But the large intestine is clearly enlarged. And you know it's the large intestine because the valvular markings do not extend from one wall to the other wall. On the second picture, let's do the second x-ray. On the upper right, and I'm talking from our point of view, so it'd be the patient's upper left, but we're looking at the upper right, you can see her stomach. And that large gas is just within the stomach. That's normal. There are no significant air fluid levels. Remember, with air fluid levels, on most cases, there'll be a flat bottom and a curved top, and they'll be large. This patient has some gas, and that's those little dots of blackness you see. But otherwise, things look okay regarding that aspect. The intestines are not enlarged, but coming out of her stomach and either entering the intestine or already in the intestine is a toy, and you can see that right in the center. Kind of looks like Hello Kitty. So this patient swallowed Hello Kitty. Okay, on the left x-ray, you can see enlarged small intestine. Number one, that's a poorly taken x-ray. That's really illuminated. You can't see the lungs, but you can see her small bowel obstruction. Second one, there's no free air, there's no perforation. You can see her stomach. You can see a lot of gas in her intestine. This patient is really gassy, but no significant number of air fluid levels. No dilated colon, it's normal size. You can see calcifications in her pancreas, so she has chronic pancreatitis. This patient, this is just another example of just a normal finding. Notice that the bowel loop is between her right hemidiaphragm and her liver. That's normal, and it's not enlarged. But what is enlarged on the second x-ray? That's her large intestine. And you can see above the large intestine is her stomach. So we don't care that there's a big old gas bubble. That's her stomach. Right, excuse me, that looks like a male. That's his stomach. But he has dilated loops of the large bowel. He has a large bowel obstruction. Okay, the first one, you can barely see the hemidiaphragm, if at all. I can't see the hemidiaphragm. That's a poorly taken x-ray, but you can see the small bowel obstruction very clearly. Second one, you can also see the small bowel obstruction because of the significant air fluid levels, and then magnets. So this patient swallowed magnets that caused the obstruction. And then with this one, I just want to review what a normal intestine looks like. So you can see her large bowel. It's not enlarged. She has some gas, but there's no significant air fluid levels. And then she has an IUD that looks like it's gotten tilted. But other than that, that's the intestines at least are normal. Most obstructions are small bowel, and that's due to internal obstruction or external compression. Most small bowel obstructions are due to adhesions. Adhesions are scar tissue, and it forms secondary to inflammation of the peritoneal lining. Generally, it follows surgery. So if you have a patient who had some sort of abdominal surgery and now is experiencing constipation and vomiting, they need a plain film very quickly. If you do see obstruction, you need to admit these patients. They will often be dehydrated because they have stool, they have poop that's just sitting there, it can't pass. So water gets reabsorbed, they become tachycardic. They have orthostatic hypotension. They do need a CT scan to evaluate for any underlying causes, but let that happen when they are admitted. Your job is done after you've admitted these patients, and then they'll get the surgical consult there. With large bowel, these are much more rare, and they're often due to colon cancer. You can see it with a volvulus. That's where the intestine just twists upon itself. But that twisting, that volvulus, is going to be secondary to something else, like cancer, or adhesions, or infection. So treatment is the same. Get those patients admitted.
Please read over this case study. Notice he is 64, 8 days duration as well. Given his age, the duration of constipation, we're going to do a plain film on this guy for sure.
What do you see? Well, you should see the hemidiaphragm, which we can't really see here. So it's not the best x-ray. You can see the stomach, and then below that you see an enlarged intestine. Now, is that the large or the small intestine? Well, the valvular markings do not cross the diameter, so that is the large intestine. This man has obstruction of the large bowel, and it turned out to be secondary to colon cancer.
All right, please email me any questions or concerns. Thanks, guys.